Good morning, ladies and gentlemen. My PhD is about maxillofacial surgery in cleft lip and palate patients. I am Alexander Schulze Wenning, a medical doctor and currently PhD and dentistry student here at Semmelweis University. My vision is to increase the healthcare accessibility for patients with cleft lip and palate by reducing invasiveness through research-based clinical decision-making. These are my two specific goals. The first one of them is a comparison of two philosophies, two surgical philosophies, how to approach cleft lip and palate, namely one-stage and two-stage palatoplasty. So what is cleft lip and palate? Cleft lip and palate is the most common maxillofacial deformity worldwide, with an incidence of 1 in 600 live births, and much more in Southeast Asian countries with an incidence of 1 in 200, 250 roughly. It results embryologically from the non-fusion of the alveolus, lip, soft and hard palate. The most common form of it is the left-sided complete cleft lip and palate. One of the main reasons for this research is that there are no universal guidelines on how to approach, how to treat surgically this problem. This was well shown by the Eurocleft survey, demonstrating that 201 different cleft teams operate in 194 different protocols. It's an astonishing number when you think about it. So, what are those two philosophies, namely the one-stage and two-stage palatoplasty? One stage could also be called simultaneous approach, and in this approach we surgically close the soft and hard palate together in one operation. The assumed benefits of them are a better speech development, since the tongue can already early on learn how to interact with an intact palate. Contrary to this, we have the two-stage approach, which separates the operation in two consecutive operations, first soft and hard palate or vice versa. Advantages of the two-stage palatoplasty are, as I said, a better maxillofacial development, since the later operation of the hard palate will be the cause of later scarring, so less hypoplastic maxilla, as they said. That's why we set out to investigate if the patients benefit more from either one-stage or two-stage palatoplasty. So our population were patients with uni and bilateral cleft lip and palate. The intervention were one-stage palatoplasty. As a comparator, we had the two-stage palatoplasty. Outcomes, we looked at cephalometry, audible hypernasality, audible nasal air leakage, as well as anterior crossbite and velopharyngeal insufficiency. Our hypothesis is that one-stage palatoplasty provides at least as good a clinical outcome as a two-stage palatoplasty. With this, we could increase the amount of operative cases performed, and especially the amount of operative cases performed in third world countries and developing countries where not every child is yet able to get a surgery, by reducing the number from 2 surgeries to 1 surgery. Furthermore, we could decrease the anesthesia exposure. This was our systematic search done in October with the search key in all of these 3 databases. We ended up with 36 eligible studies in the end. The first result which I would like to show and introduce to you is the U1PP angle, the angle between your upper incisor and the palatal plane. It's a very important angle for the soft tissue aesthetics of the face, especially for your lip, for your upper lip. Here we could show that the one-stage surgery has a statistical significance favoring the one-stage surgery compared to the two-stage surgery. The second outcome, which I would like to introduce to you, is the velopharyngeal insufficiency. It means the ability of your soft palate to properly close against the pharynx. Here we could also show a statistical significance favoring the one-stage approach. Continue with the velopharyngeal insufficiency is the audible nasal air leakage. As you could imagine, if the velum can't properly close, more air is able to escape through the nose while vocal speech. Also here we can see a statistical significance favoring the one-stage approach. Another outcome for speech development is hypernasality. Hypernasality in this case didn't show statistical significance, but still a clinical significance favoring the one-stage approach, since in most articles the occurrence of a severe hypernasality is more common after two-stage surgery. The next outcome is the stellar nasion A-point angle. This is the angle between the base of the skull and the most concave point of your maxilla, the A-point. This is one of the most crucial parameters for the palate and the palate development, since an angle of roughly 82 degrees constitutes a normal development, anything less or more either retrognathic or prognathic maxilla. Here we could show, very importantly, and with most data points we have, that there is no significance favoring one method over the other, which is then indicative of a one-stage approach should be considered. The same accounts for the sellar-nasion palate plane angle, so the angle between the base of the skull and the palatal plane. Also here, there was no tendency favoring one method over the other. The next result is the A and B angle, the angle between the most concave point of the maxilla, the nasion, and the most concave point of the mandible. This is a very important angle for the occlusion of your upper and lower jaw. Here we could also show there is no tendency favoring one method over the other, with this also supporting the one-stage approach. Also, anterior crossbite did not show a tendency favoring one method over the other. As a conclusion, the maxillofacial development does not differ substantially between one-stage and two-stage surgery, but one-stage surgery provides better speech development. So, in general, one-stage surgery could be or should be the operation of choice for most cases. Definitely more studies are needed to be done with the exact timing, and what would be really interesting is to see more studies with exact cleft width description, so to develop a protocol which really takes into consideration the shape and the size of the cleft to then decide which surgery should be done. The strengths of our study are that it is the most comprehensive study up to date and the only one comparing multiple variables together in one study, and it's the only one with the subgrouping of the different types of two-stage surgery. There are a few limitations to the study as well. Unfortunately, there were no RCTs involved, only retro and prospective designs, and huge different numbers of operation techniques performed. For our manuscript status, it should have been submitted yesterday evening. Unfortunately, this was not possible, so it will be submitted tomorrow. It will be then submitted to the Journal of Cranio-Maxillofacial Surgery. My second topic is the proof of concept meta-analysis. It is the investigation of the clinical applicability of salivary microRNA as an early cancer diagnostic factor. Cancer treatment and diagnosis has improved over the last decades by many, many folds, but it's still one of the leading causes of death. Why is it so? Because early detection is still lagging behind in many cases. For example, pancreas cancer or lung cancer. Most often it is found incidentally or when already symptoms do occur. Blood plasma microRNA has been shown to be a feasible early diagnostic marker for cancer, but saliva is better. For saliva, we don't need any specialists to draw the blood, so there is no infection risk, no needle prick injury risk, and also the accessibility for saliva microRNA testing is much higher than for blood plasma. Research from last year has shown that saliva microRNA has a specific expression pattern possible to identify the tumor origin. Furthermore, research from last year has shown that microRNA is stable and abundantly found in saliva. That's why we set out to investigate if the saliva microRNA as a clinical applicability of salivary microRNA as an early tumor diagnostic marker. Our population were patients with cancer. In general, any kind of cancer. We look at the intervention at salivary microRNA as a comparator blood plasma microRNA, and outcomes we will check are sensitivity and specificity. Our hypothesis is that saliva is as sensitive and specific as blood plasma samples in early tumor diagnosis. With this, we could enable early targeted treatment, which is accessible basically for everyone. This is our systematic search done in June in those 3 databases. Currently, I'm on data extraction, as you can see, and the goal to finish in the end of September, the second project. With the words of Walt Disney, if you can dream it, you can do it. I'd like to thank you for your attention. If you have any questions, please feel free.
Okay, thank you. I just want to ask what favors the two-stage operation in your first topic? Mm-hmm. Because what you tell is that we should immediately change to one stage.
Yes, as we can see from all our results, none of the results were actually favoring the two-stage approach. They were either equal or in some regards, the one stage was better, but it's still pretty limited, our results. There's a huge heterogeneity, and also as I spoke with a few surgeons, they say that their clinical knowledge shows something different. So to say we should immediately, everybody should change their protocols, which are performed for many decades in the hospital, is maybe a step too far. So we need more research there, but so far it's showing towards this direction that one stage should be the operation of choice in the beginning.
Thank you so much.
Thank you, Dinesh.
Congratulations, Alex. Fantastic progress. I have a question. It's kind of a comment, probably, because you were introducing at the beginning that there are like you introduced that there is a study with 200 work groups or surgery institutions, yes, departments with almost 200 methodologies, actually.
Yes.
Of course, I know that in this case it's very hard to actually bring your results to all of these 200 groups and actually convince them to start to use one or the other one. But still, I'm wondering if in this group, is there any specific method how to convince them? Or also, I'm very curious how they will read your paper, what will be their opinion, because there are 200 other opinions as well.
That's true. It's a really good question, and what we were discussing as well. It will be probably challenging to convince everyone, and probably impossible to convince everyone. But of course, by submitting in a very good journal and by the repetition of submitting and more articles and more research on this field, which hopefully will all show that one stage is the operation of choice, over time we'll convince more and more surgeons to conduct the one stage rather than the two-stage surgery. And then I think it's a progress of time that then they will teach their new surgeons as well about one stage more than about two stage. So hopefully in the end it will deviate to this.
First of all, the 200 groups and 200 different methods, it's not really true because there is a guideline how to treat cleft patients. Second, we also have a team, a cleft, lip and palate team in Page, and we recently established a registry in the field of orthodontics, and we would like to extend to all the other fields. So I'm just highlighting the perfect candidate to connect Page group to the Semmelweis group to improve this registry in the field of maxillofacial surgery in cleft surgery.
That would be amazing.
So you are invited, actually.
Thank you very much, Professor Nagy.
Thank you.